I'm very happy to welcome you all to this webinar today on a very important topic. And we have a very distinguished speaker also. I am Dr. Ashok Kumar Agarwal, and I'm also very happy to welcome the honored speaker, Dr. Manish Nakra. Dr. Neeru Bhatia is also there. You can see on the screen. And good afternoon, Dr. Manish, and welcome you for this webinar. You see, let me say a few words about myself. My name is Dr. Ashok Kumar Agarwal, and I am the former director of the School of Health Sciences of Indira Gandhi National Open University, and also working at the moment as the advisor to the Astron Institute of International Studies. As you all are aware, the Astron Institute of International Studies has been recently accredited by NABET. NABET is the National Accreditation Board for Education and Training, which is another board just like a NABH board. And this happens to be the first institute to be accredited by NABET for the online training programs. About the Astron has got large number of training programs, and most of them have been accredited by the NABET. And another thing that the Astron Institute has recently started is the e-college. The Astron e-college is an online portal for the working professionals, especially catering to the health sector and the health professionals. These courses in the e-college are of the around 2 to 3 hours duration, and they are the video-based pre-recorded sessions. And the courses comprise of the various modules and assignments. And on completion of these courses, all those who enroll in these courses will get a internationally recognized certificate with the lifetime validity. And in addition to the health courses, we have certain courses in the e-college which are of general in nature. For example, building up the soft skills, motivational skills, banking, finance, and similar things are there for which interest the general students. Now, for more details about the e-college, you can always visit the Astron website, which is the www.astronecollege.com. And well, without taking any more time, let me introduce the honored speaker, Dr. Manish Nakra, whom you can see on the screen. And Dr. Manish Nakra is a medical graduate from Armed Forces Medical College, like me, myself. And he is heading the Department of Critical Care Medicine at the Venkateshwara Hospital, Dwarka, New Delhi. And he is, in fact, a DNB examiner, teacher for the various Indian Society of Critical Care Medicine courses like ID, CCM, and the CT, CMM. And he has got large number of publications in important journals, national, international, like more than 20 publications in the index journals, and authored chapters in the various critical care books. So we have a very good speaker, and I would request that all of you should listen to him carefully. And then at the end of his presentation, maybe that if you have any questions, please do raise those questions, and then he'll be very happy to answer. So with this, let me hand you over to Dr. Manish Nakra, please. Dr. Manish Nakra.
Good afternoon, ladies and gentlemen. I'm Manish Nakra. I'm head of critical care medicine at Venkateshwara Hospital in Delhi. And I would be speaking today on healthcare associated infections in the ICU, as in relation to their quality indicators. What do they imply, and how do we, of course, prevent them? At the outset, thanks so much, Dr. Ashok Agarwal, sir. It indeed is an honor to be amongst you people and addressing an august audience like this. Thank you so much, Dr. Neeru Bhatia ma'am, for giving us the opportunity interacting and being a part of your esteemed college. Thank you so much. And I would now move on to my healthcare associated infections. What do they stand for? So HIAI infection is an infection occurring in a patient during the process of care in the hospital, which was not present or incubating at the time of admission, but happens on the 3rd calendar day of hospitalization. Now, this is important here. What you have to really know is each word is important. It was not present or incubating at the time of admission, but happens on the 3rd calendar day of admission. That means day 1 is your first day. And if it happens on the 3rd day onward, it becomes a healthcare associated infection. That is why it becomes very important when we talk in terms of healthcare associated infection. Suppose a person is coming in from the society. He comes in with a pneumonia, which you don't pick up on day 1, but you pick up on day 2. That doesn't become HEI just because he's got admitted to you, right? So that's something, that distinction is something that you have to really be aware of. In low and middle income countries, the frequency of ICU acquired infection is at least 2 to 3-fold higher than that in the high income countries. And also device associated infection densities are up to 13 times higher than those that we see in the USA. Now, this is really a troublesome thing, and this is something that we really have to act upon. It is also said that healthcare associated infections kill more people in a year than a jumbo jet crashing every day of the year. Now, this is something which has been said for a long time. But this is something which a lot of us have not sat up and take cognizance of. So that's something which is very important, that we have to be really noticing that healthcare associated infections is something which is preventable and can be incorporated in your day-to-day practices so that you don't land up with these kind of fatalities and these kind of figures, because the cost of prevention is only minuscule when we compare it to the cost of the treatment that is going to be there. So that's something which we all have to really be seeing, that remember, it is, yes, prevention is better than cure. Everybody knows that. But here, when the economics come in, this is something which becomes really important. Another important factor here before I really move on from here is that healthcare associated infection is the same thing, which in the past used to be called nosocomial infections. So healthcare associated infection is the new terminology. To prevent, we have got, of course, the role of the infection control nurse. Who else but them? And ICNs are primarily associated with ensuring implementation and infection control practices by the healthcare workers. ICN is the link to the HICC and the wards of the ICUs in identifying the problems and, of course, implementing the solutions. The minute we talk about infection control practices in critical care units, the first thing which comes to our mind is the design of the unit. There has got to be adequate space around and between the beds. Now, that's something which is absolutely, I mean, you cannot move on beyond that. You can't have beds which are going to be right adjacent to each other, and then you expect that you are going to be having adequate infection control practices. It doesn't work that way. You would, of course, need a single closed negative pressure, which is required for patients needing isolation. And these patients would invariably be patients of tuberculosis, which is like so endemic in our country, patients of H1N1. These are the patients who require your single closed negative pressure rooms. Good housekeeping practices are to be followed. Now, this is something which we can do on a day-to-day basis. So this is something which is implemented. The minute you walk out and you say, okay, I want to bring out one change, this is the first change you can do, because you can, and it doesn't really take too much. What it really has to say is regular cleaning of all the areas, maintenance, linen and curtain changes, etc., and cleaning floors at least 4 times in a day. And of course, grooming is absolutely not permissible at all. What you really have to be following is your 5 moments of hand hygiene. This we all know what it is all about, but still, this has to be re-emphasized over and over again. Before you touch a patient, after you touch a patient, before you do any clean or aseptic procedure, after body fluid exposure, and of course, after touching patient surroundings. So you've got 2 befores and you've got 3 afters, but make sure you wash it or make sure you clean it. Either you would be doing a hand rub or you would be doing a hand wash. Now, what is it to be done? A lot of people I see are confused at a lot of times, but this is very simple. If your hands are visibly soiled, wash them. If your hands are not visibly soiled, go ahead and rub them. The technique remains the same. If you see on both the pictures, the left and the right, 2 to 7 steps are the same in both the slides. But when you do a hand rub, it'll be a 30-second procedure. When you do a hand wash, it'll be a 60-second procedure. That is the difference. But otherwise, the steps essentially remain the same. And again, to be re-emphasizing the fact, if your hands are soiled, wash them, because a rub will not take blood and secretions off your hand. So you have to be washing. That's something which is very important. Now coming down to the main crux of the topic, which is infection control indicators. Specifically, we would be talking about infection control indicators related to the ICU. So here, we will be just talking about these 3 for now, which is WAP, CLABSI, and CAUTI. WAP is ventilator-associated pneumonia. They are the number of patients who developed VAP upon the total number of ventilator days into 1,000. CLABSI is number of patients who developed CLABSI upon the total number of catheter days into 1,000. And CAUTI is, of course, total number of patients who develop, number of patients who develop CAUTI upon the total number of catheter days into 1,000. CLABSI is central line associated bloodstream infection, which can also be called, which is also called sometimes as CRBSI, which is a catheter-related bloodstream infection. CAUTI is, of course, a catheter-associated urinary tract infection. So you got your VAP, which is your pneumonia, you got your bloodstream infection, and you got your CAUTI, all three related to devices. Now we come down to the concept of a care bundle. A care bundle identifies a set of key interventions deriving from evidence-based guidelines that, when implemented, are expected to improve the health outcomes of patients. Now, it is important here that you realize that there are a bunch of bundles, there are a bunch of activities or interventions which are supposed to be done. You can't say, okay, so I've got a care bundle which has got 5 interventions. I will do 3. So I'll do 3 out of 5, which is like good enough. At least I'm making some headway. No, that is not the way it works. A bundle is a bundle. You are supposed to incorporate it all together. I'm not saying it's an all or none, but it works the way that it's supposed to work when you're putting it all together. You can't say, okay, I'm just going to be doing 2 of this. If I'm doing 2 of this, at least my ICU is better than what it was before. Yeah, in a sense of the word, is better than what it was before. But as in the final outcome, where you're trying to prevent any hospital-acquired infection or hospital-associated infection or healthcare-associated infection, this is not really going to be working for you. So the first thing is VAP. Now, if the patient is on mechanical ventilation and signs of infection appear after 2 days of stability or improvement on ventilator, the VAP is recognized by the following criteria, which is worsening oxygenation, the temperature going up or down, WBCs going up or down, and patient having purulent respiratory secretions and a positive microbiology culture. Now, each of these words is important and they have to be adhered to and followed in letter and spirit, which I will just take a little time longer in the next 2 slides. The next 2 slides are snapshots of the latest CDC guidelines of January 2022. Now, I request you that these are the 2 most important slides in the whole lecture. So I request you that all of you just sit up and listen to this. This is the way it goes. Now, if your patient, let me just put this on the side. If your patient has a baseline, I'm right here on the first, we are talking about ventilator-associated events. Now, when we are talking about this, we are talking about a surveillance algorithm which is happening. How does it happen? Your patient has a baseline stability or improvement of the ventilator. Very important. He's got a baseline stability or improvement, which is defined by 2 or more than 2 calendar days of stable or decreasing daily minimum FiO2 and PEEP values. So your patient is either coming down on the FiO2 or coming down with PEEP value. So this is either he's stable or he's improving. When you say improving, his FiO2 requirements are coming down, his PEEP value is coming down. Now the baseline period is defined as 2 calendar days immediately preceding the first day of increasing daily minimum PEEP or FiO2. Suddenly a PEEP or FiO2 goes up. Now the previous 2 days will be your baseline period. So daily minimum defined by the lowest value of FiO2 or PEEP during a calendar day that is maintained for an hour. So if your PEEP or if your FiO2 is maintained for an hour during that day, that is taken as the daily minimum. That's something which is absolutely got to be very clear. Number 2, after you've got your daily minimum and your baseline clear, next we come on to the next step, which is after a period of stability or improvement of the ventilator. Now the patient has one of the following indicators, which I spoke about in my last slide, of worsening oxygenation. That is the FiO2 increases by 20 points. When I say 20 points, I mean 0.2. Okay. So 1 is taken as 100%. When we say 0.2, you mean 20%. So if your FiO2 was 40%, that is 0.4. Suddenly it has gone up to 60%, which is 0.6. It has increased by 20 points. Over the daily minimum of the first day in the baseline, and it is sustained for 2 calendar days, your patient is going down. Next is, there is a decrease, there's an increase in the daily minimum PEEP of more than 3. So that was by 20 points. This is by 3. over the daily minimum PEEP or the first day in the baseline period, and which is again sustained for 2. Remember, this deterioration has to be sustained for 2 calendar days. Give you an example. A patient is there for 2 days. He's kind of stable. Suddenly, on the third day, his FiO2 requirements have gone up and the PEEP has gone up. On the 5th day, his FiO2 requirements have come down, his PEEP has come down. Then he doesn't fit into that criteria because it has to be sustained for more than 2 calendar days, 2 or more than 2. Daily minimum, we've already talked about, defined by the lowest value of the PEEP and FiO2, and it has to be maintained for more than an hour. That's something which is very important. Again, to give you an example, I'm trying to give you examples here because these are situations which you will face in your day-to-day functioning. And this is what will help you decide and clear up your mind, because people are going to be asking you, you tell us whether this fits into the criteria. So you will say, no, if it is not sustained for an hour, it doesn't amount as baseline. Remember, daily minimum PEEP values of 0 to 5 are considered to be equivalent for the purpose of ventilator-associated event surveillance. The minute you've got this, your patient has got a ventilator-associated condition. Now it has become a condition, but we still don't know whether it's infection-related. He's got a condition, ventilator-associated, but we don't know whether it's infection. To say whether it's infection, on or after the day 3 of calendar day of mechanical ventilation, and within 2 calendar days before or after the onset of worsening oxygenation, the patient meets both the criteria. It's not all or none, both. So your temperature is going up or your WBC is going up or going down, and you've added on 1 new microbial agent. If you have done that, that means you have changed your antibiotic, your patient starts having fever or WBC is increasing, you have got an infection-related ventilator-associated complication. So what was a ventilator-associated condition has now become an infection-related ventilator-associated complication. This is something that you have to really remember, because this is the time where it has become an infection. Now, our next step is to say it is VAP or not VAP. So this is what happens. Now, on or after day 3 of mechanical ventilation and within 2 calendar days before or after worsening oxygenation, one of the following criteria has to be met. Criteria number 1, you got a positive culture and the positive culture has shown endotracheal aspirate of 10 to the power of 5 CFUs or a BAL of 10 to the power of 4. These are the more 2 common ones. We won't talk about the lung tissue and the PSB, which is the protected specimen brush. I'm not trying to confuse issues here. This is available. This is on the CDC guidelines of January 2022. Now, remember, for this, there is no requirement of a purulent respiratory secretions because there is a positive culture and it is fitting into the CFUs. So you've got a positive culture fitting into the CFUs. You really don't need to be having a purulent respiratory secretions. But suppose you've got a positive culture which is not in that zone of 10 to the power of 5 for an ET aspirate and 10 to the power of 4, then what you really need is purulent respiratory secretions, which are defined as secretions that contain more than 25 neutrophils or less than 10 squamous epithelial cells per lower power. So that's something which is important. Then there is a third criteria. Suppose you don't have purulent secretions or you have not grown a bug there. You have got an organism which is identified from the pleural fluid within 24 hours of chest tube placement. Remember, anything more than 24 hours are not eligible for PVAP. What is PVAP? Possible ventilator-associated pneumonia. Next, you've got a lung histopathology, which has shown abscess. You got diagnostic test for Legionella species because it doesn't pick up here. Or you got diagnostic test of any kind of these viruses, which again is not picked up here. So if you have any one of them, this becomes your criterion 3, and then you possibly have a possible VAP. What has changed? Some additional information I'm trying to give you in the latest CDC guidelines as against the previous one. Previously, there was a probable and a possible VAP. Now, CDC has made it simple, and they have said all this will point towards possible VAP. So you got a possible VAP. So if any one of you is involved in VAE surveillance, this two slides become the most important slides when we are trying to reach to a quality indicator. Now we come down to the care bundle. This is the care bundle. You've got 4 features: elevation of the bed of the ICU of the patient between 30 and 45. Sometimes I go to other ICUs for whatever reasons, and I see as examiner or whatever, and I see the beds are below 30 degrees. So if you've got a patient who's lying flat on a bed, if he doesn't have indication to lie flat on the bed, you're in a primitive ICU. You definitely have to have your bed elevated to 30 to 45 degrees. Peptic ulcer disease prophylaxis, very important. DVT prophylaxis, unless it's contraindicated. Suppose your patient has got a bleeding problem. Suppose your patient's INRs are deranged. Suppose your platelets are low. Suppose your patient has got high creatinine. You don't want to give LMWH. In that case, you may not. But otherwise, DVT prophylaxis has to be given. Whether you give mechanical prophylaxis or you give chemo prophylaxis, I'll leave that to you, but it has to be. In our hospital, I'll give you an example. We even go on to use, algorithms and scoring systems which tell us which of our patients are at risk. So we've got, say, something called a Caprini risk index, and we've got a modified Padua. Caprini risk we use for our surgical patients. Modified Padua we are using for our medical patients. So this is what we are doing even for risk assessment. It's not just eyeballing. It's not that I cross a patient in the morning and I say, yeah, let's start off DVT prophylaxis with this guy. No, it's not like that. It's very objective. We have a form, you fill up that form, and he meets the criteria as being one of the risk criteria, we do it. Daily mouth care with chlorhexidine, very important. We may disregard it, Isse kya hoega? No, very important. Daily mouth care with chlorhexidine has shown to be. And remember, all of this is a bundle. It's supposed to go together. You can't say, I'll elevate the bed and other 3 I will not do. That is not the way it works. Now we'll talk about the strategies to prevent VAP. So first is the maintenance of in-use respiratory therapy equipment. So for this, the fluids used in the humidifier should be sterile, needless to say. You can't just take tap water and fill it up. Disposable supplies such as laser prongs, masks, ventilator circuits are for single patient use only. You can't be using it in between patients. You maintain ventilator circuits, that is, you change the ventilator circuit only visibly soiled or malfunctioning. And you change the ventilator circuit as needed rather than on a fixed schedule. So it's not that, okay, it's a Monday, we will change our ventilator circuits. That is not the way it is going to work. You have to be changing your circuits only when there is visible soiling. And otherwise, there is no evidence at all in case you are looking at just changing a ventilator circuit just because it is the day of the week. Or say sometimes a lot of ICUs, I think, who have possibly, they tend to spend a little more money and they think money is all healthcare and quality. That is not the way. It's not that every morning you say, or change all the circuits. No, you only change it when you really need to be. You see it as visibly soiled. Processing reusable equipment. All equipment to be sterilized or disinfected should be thoroughly cleaned first to remove organic materials such as blood, secretions, or other residue or soil. So remember, you want to take blood and secretions off, you have to be washing it. You cannot just put it as and send it for sterilization without having cleaned it as to wash it. Thoroughly clean it, wash it, and only then. Whether it's your hands or whether it's the equipment, the policy remains the same. Coolant chambers for ultrasonic nebulizers are difficult to disinfect adequately and should have at least 30 minutes contact. Because they're difficult to disinfect, so you have a higher contact. So you have a 30 minutes contact with a high level disinfectant or be gas sterilized, that is ETO. This is not, of course, necessary in case you're using. Another one is sectioning of the respiratory tract. Very important because you would be doing it so often. Judicious suctioning to be done. And what do I mean by judicious suctioning? It is not that every shift to show that you have done a great job, you're going to be sucking the patient thrice. That is not really good. Do it if there are secretions. That is why a lot of ICUs, a lot of good ICUs, which are run by critical care people, where intensivists, they would talk about that, listen, how much were the secretions in your thing? How many times do you really need to do a suctioning? It is not that I will do a suctioning every 2 hours. It's not like back care. It is not like positioning of the patient. Suctioning to be only done in case the patient needs to. Because if you do more than needed, you will cause trauma. Because you will cause trauma, they will be bleeding. Because they will be bleeding, there would be more infection. So that is something which is not got to be done. Suctioning should be done using gloves and masks. A sterile catheter to be used for each series of suction. Now, what do I mean by series? You've come in here, you're wearing gloves, you've done a suctioning, and you moved off. You want to suck again, you will suck again, and you will move off. This is one series. Now, after 10 minutes, he needs suctioning again. That's series number 2. When he needs series number 2, he or she needs series number 2, you will change your catheter. This catheter, of course, you would have discarded at the end of the first series, and this now you will use a fresh catheter. That is what is meant by a sterile catheter should be used for each series of suction. Catheter should be flushed with sterile fluid in case flushing is needed, and fluid should be discarded. You can't be. A lot of places I'll see. I mean, I don't want to be naming hospitals. I would not want to be saying, government versus corporate or anything like that. But a lot of places I'll see, you got these bottles which are cut open, half open, IV fluid bottles. And the suction catheters are hanging from that. People are using the same bottle for, no, you're not supposed to do that. And then you say that my patient has got VAP. Obviously, your patient will have VAP. I'm surprised he's got VAP so late. He would have got VAP much earlier, right? So suction containing tubing and suction canisters, of course, should be changed daily for ongoing patients. Now we come down to CLABSI, which is central line associated bloodstream infection, which is also called CRBSI, which is central line related bloodstream infection. So CLABSI is a primary laboratory confirmed bloodstream infection in the patient with a central line at the time of onset of the symptoms, and the infection is not related to an infection from another site. So that's something which is very important. There is a concept which is called a differential time to positivity. I will not tell you too much about it. I will just give you a little bit of an indicator so that it's a little bit of a stimulus that you guys would know that this kind of thing exists. DTP is a differential time to positivity. You will take, suppose you feel that your central line is your incriminating device. You will take a sample from there. You will take a sample from peripheral line, and you will send these two samples together. You will see what is growing and how soon it is growing. Suppose the time difference is too much. The cutoff is taken as anything from 30 to 2 hours, 30 minutes to 2 hours, which is taken as the cutoff when we talk about that, where you can actually incriminate the line and say that this is the line which is causing it, right? So just suppose you got one sample here and one sample here, and it may grow the same thing and may not grow the same thing, and you say line is the source. That is not the way it works. You have to be following something called a DTP. CLABSI care bundles, 2 major bundles, insertion bundle and maintenance bundle. Remember, the breach can be anywhere. So this is something which is very important. Insertion first. This is where the operator is doing, the person who's inserting it. Maximal sterile barrier precaution, surgical mask, sterile gloves, cap, sterile gown, sterile drape. And the drape has to be full body drape. It is not that you take a cut piece, keep it here, and then you're saying that, oh, this is it. This is good enough. No, this will not be good enough. Skin cleaning with alcohol-based chlorhexidine. Avoidance of femoral line for central venous access in adult patients. Use of subclavian rather than jugular. In order of priority, it should always be subclavian, jugular, and then femoral. If you had to put in a femoral, make sure you change it at the earliest to an internal jugular or a subclavian. Availability of insertion guidelines for central line use and use of checklists with trained observers. This is something which has again been documented by the ICMR. ICMR came out with guidelines for prevention of healthcare associated infection, which came out in 2019. These are straight from there. So they have even talked about user checklists and trained observers. So a lot of NABH hospitals, when they talk about, they say, okay, central line are the educators, are the nurse educators, or are the ICNs, or are the link nurses, are they involved by instituting some form of trained observers who are going to be putting in the light? So this was your insertion bundle. Next, we come down to the maintenance bundle. Maintenance bundle is on day-to-day thing. Daily review of central line necessity. Just don't let a line lie there. Just because it is convenient, so that you don't have to prick again and again, so that the nursing staff doesn't have to prick again and again. Or the nursing staff feels, oh, there's a little bit of edema, let the central line be there. That should not be it. Because remember, any device which is in has got to have a chances of infection. You don't want that device to be in. So in case you are not needed, suppose the patient is not on inotropic support, suppose the patient can very well be taken on a peripheral line, suppose the peripheral venous access is available, go ahead and take it, remove the central line. Prompt removal of unnecessary lines I've talked about, disinfect catheter hubs, ports, etc. before using the line. Change dressings and disinfect site with alcohol-based chlorhexidine every 5 to 7 days. So regular dressings, do not change it earlier than 5 to 7 days. Do not remove the dressing because it has been seen that you keep on removing the dressing to inspect the site. No, that is why you're supposed to have transparent dressing so that you can see, you can look for any erythema, you can look for any redness, you can look for any purulence. But you're not supposed to be taking it out and cleaning it because it's a kind of a breach. And if this dressing is getting soiled, and particularly in the Indian this thing, because we are tropical countries, little bit because of the hirsutism pattern that is there, little bit of the excess sweating that is there in our Indian subcontinent. So maybe here we might have to prepone our dressing change a little earlier because they might get a little soiled, but that window has already been given to you. You've already been told that you can change it earlier if they are soiled. Replace the administration sets within 96 hours and immediately if you're using it for blood products or lipids. So if you use the administration set for blood products or lipids, you will change it immediately. Otherwise, every 96 hours. Ensure appropriate nurse to patient ratio in the ICU. I know a lot of times you may not have a say in that. You'll say, oh, what can I do? I'm not the one who gives the nurse to patient ratio. I've been asked to look after so many patients, so I'm looking after so many patients. Yes, but make sure you try and bring it because at some point in time, you will be rising up in hierarchy. You will be going up in hierarchy. And at the same time, your role as an infection control nurse, your role as a TL, your role as the person who's managing your patient, your role as the in charge has got to be that you raise the levels and communicate to the people higher up that can we have a more ideal NPR, where we are looking at 1:1 for ventilated patients and 1:2 for otherwise. So that's something which again becomes your role. When we talk about strategies to prevent CLABSI, you would of course start off with education. So educate healthcare workers regarding the indications for intravascular catheter use, proper procedures for insertion and maintenance of intravascular catheters and appropriate infection control practices. Periodically assess knowledge of and adherence to all guidelines for all personnel involved in the insertion and maintenance of intravascular catheters. Ensure appropriate nursing staff levels in the ICU. When we talk about aseptic use technique using CVC catheter insertion, there has to be strict adherence to hand decontamination and aseptic technique shall be practiced. Maximal sterile barrier precautions shall be used, regardless of whether the placement takes place in the OT or the ward. This should include the use of a sterile gown, gloves, cap, mask, and a sterile full body drape. I'm re-emphasizing again because this is the place where we all go wrong. Sterile full body drape for insertion of CVCs or peripherally inserted central cannulations. Skin prep has to be done with 0.5% chlorhexidine preparation with alcohol before insertion of a central venous catheter or peripheral arterial catheter and during dressing changes. Aseptics should be allowed to dry before insertion. That's something which is very important because otherwise it won't have the desired effect and it won't stick. Care of the monitoring pressure monitoring system. Keep all components of the pressure monitoring system ready, including calibration devices, flush and flush solution, etc. Sterile. Minimize the number of manipulations of and entries into the pressure monitoring system, basically trying to tell you to try and use a closed flush system that is continuous flush. We used an immensely closed system in our place. Of course, I'm not here propagating any one particular product, but you can take your choice about what you would want to really be using. Wipe the diaphragm and an appropriate antiseptic before assessing the system. Next, we come down to the last segment of the talk, which is CAUTI, and it is defined as an infection which occurs with the urinary tract in which positive urine culture was taken, where an indwelling catheter was in place for more than 2 calendar days on the day of the event. So this is something which is very important, more than 2 calendar days on the day of the event. Again, everything that you will see, 48 hours, VAP, 48 hours, bloodstream infection, same, CAUTI, same. So remember, but by and large, you won't have patients coming in from another hospital with your central line, but suppose it is, that is the way that it's got to be really seen. Insertion bundle, again, it's got an insertion and a maintenance bundle. Verification need prior to insertion. Insert urinary catheter using aseptic technique. Secure catheter to prevent irritation of the urethra, very important. If your catheter keeps moving, it's going to cause a lot of irritation to the urethra, and that itself could lead to start of an inflammation cascade where it will lead to more prone to infection. Maintain the drainage bag below the level of the bladder and off the floor. This is something very, very important. A lot of times the patients are shifting, suddenly the bag is on the bed. A lot of times you will find after it has been emptied out, the bag is on the floor. The housekeeping staff has put it on the floor, it's there on the floor. Till the nursing next shift realizes that it's on the floor. These things have to be monitored. Perform hand hygiene before and after each patient contact. individual labeled collection containers at the bedside. Very important. The collection containers should be with the patient. So each patient should ideally have, and this is what should be encouraged. Maintenance bundle, daily documented assessment of need, catheter secured. That means the device to secure the catheter is in place. Hand hygiene performed for patient contact. Daily meatal hygiene performed with soap and water. So either you can do it with soap and water or you can do it with povidone iodine, entirely up to you. But make sure daily meatal hygiene is performed. Drainage bag emptied using a clean container, and you should have unobstructed flow should be maintained. No kinking is permissible. A few strategies to prevent. First, of course, we start off with the indications. Make sure the urinary catheter shall be inserted only when necessary and left in place for as long as necessary. It is not a matter of convenience. Use urinary catheters in operative patients only when necessary rather than routine. Just don't go ahead and use it routinely. Oh, post-op patient, let's catheterize. No, that is not the way it should be done. And for operative patients who have had an indication for indwelling, remove the catheter as soon as possible, preferably within 24 hours. You know, a lot of good places I see a lot of good nursing staff. So that's what I distinguish a good nurse from a person just doing the job. She'll turn around and ask you, or he'll turn around and ask you that can we go ahead and remove the lines? Remember, any lines and tubes which are there should be removed if it's not needed. So that's something which is very important. That always look at the patients. Make sure that you communicate. Suppose something is missed a clinician. Sir, do we really require to put this, let this line be in C2? I think we should remove it. Remove the outline. Remove the C line, remove the Foley's. So it should be always, you should always be on. Why aren't we starting Clexane for this patient? Why is this patient not on any proton pump inhibitors? Or why is this patient not on the H2 blockers? Why is this patient not on the sucralfate? Why is this patient flat? Why aren't we feeding this patient? So that's something which is really got to be something that you have to be really seeing it day in, day out. Next thing was catheter insertion. Thoroughly wash hands or use alcohol-based hand rubs before inserting the catheter. Catheter should be inserted using aseptic technique, using sterile gloves, drapes, sponges, and an appropriate antiseptic solution for periurethral cleaning, and a single-use jelly pack. Remember, single use. Nothing, no jelly which has been used for somebody else. Oh, get the same one. We'll use the same one. Usme to sirf aadhi use hui thi. That's not the way that you would want to function. Right? It's got to be a single use. It's got to be discarded. If you want to be really making a difference, these are the strategies. We can't mandate it, but it should be done. Indwelling catheter should be properly secured after insertion to prevent movement and urethral traction. Now the maintenance. This is something that you people are involved with totally. Maintain a closed drainage system. If breaks in aseptic technique, disconnection or leakage occurs, the catheter and the collecting should be replaced using it. So if there's a break, please go ahead and replace it. Keep the catheter and collecting tube free from kinking. Collecting bag should be below the bladder level. We already talked about this. This is very important. And this is the place where we mess up the first. Indwelling catheters or drainage bags should not be changed at routine or fixed intervals. It's not that, okay, every morning we will change. No, you don't really have to change it. Suppose you see sediment, suppose you see soiling, that is the time that you're going to be changing your catheters and drainage bags. Other issues that we can talk about is changing the drainage bag when inserting a new catheter. Also change the drainage bag when it becomes stained, clouded by sediments or leak. This is what I've just talked about. In case you want a urine sample collection, urine is collected from the sampling port after cleaning and disinfecting the port with 70% alcohol. Remember that. Urinary catheter bag is emptied every 6 hourly or before it becomes 2/3 full. Don't allow. A lot of times I see the bag is overflowing, almost overflowing. That's not the way. So please empty it out every 6 hourly. Suppose the patient is not passing that kind of urine, empty it when it's 2/3 full. So whatever, but it's got to be emptied routinely. I finished with the major quality indicators. I'm just giving you one more quality indicator, which is not related to the ICU per se, which is a SSI, which is a surgical site infection. I'm only going to leave you with this slide because it is not related to the ICU. This will require a separate thing because you can even have a SSI in the ward. So we are not talking about this. A surgical site infection is an infection that occurs after surgery in the part of the body where the surgery took place. So this is your SSI, but we are not going to be talking about it. I have finished my talk. If there are any questions, I would take them on.
Thank you very much, Dr. Munish. It was a very wonderful presentation. Actually, I stand to learn many things from your presentation, and very practical points you have touched, which are, many times are ignored in the day-to-day functioning of the ICU and critical care medicine. So friends, any questions from your side? Please do throw these questions immediately. In the meantime, Dr. Manish, I just wanted to be educated about what are the latest, what is the latest, take on the fumigation practices. Do we practice the fumigation these days in the OT and the ICU, or mainly the operation theaters? Is it of any use or not practiced now, fumigation?
Okay. Okay, so I'll tell you about fumigation per se in the ICU, sir. In the critical care areas, fumigation is out. It's not done anymore.
Yeah,
so nobody does fumigation anymore.
Yes.
What we really do is we do surface disinfection.
Right.
So after each patient leaves, you have got to have a total mop down. The mop down of anything the patient could have touched or secretions from his body could have touched. Meaning right from the IV stands to the bed rails, to the bed head, to the cardiac table, to anything that is around the patient, there will be to the mattress, everything. There's a complete mop down. Yeah. Once there's a mop down and you have done this, I think there is absolutely no indication for a fumigation.
I agree.
Fumigation is only a thing when you've got, say, something like an epidemic breaking out or something like that. Otherwise, routine, ICUs, fumigation, because a lot of time this comes in from the surgeons. We're having a lot of infection here. I think this place should be fumigated. No. So that is not the way it is supposed to be done. You're not supposed to be. You want the walls will be mopped down. We'll mop down the walls for you. We will mop down everything. But to fumigate it, it doesn't make sense.
Yeah, it leads to a lot of wastage of time, energy, and money. And same principle is applicable to the operation theater also. No more the fumigation is practiced. I think the zoning of the operation theater, positive air pressure, and all those things, and the things that you mop down, you said, are the very practical things. Yes, any questions, gentlemen, ladies? Anything from Dr. Neeru Bhatia or from Polomi?
Okay, thank you so much, Doc. It's actually been something which there's been a great learning into it, and you're a perfect and a very, very good teacher. The way you have been conducting this webinar, something as if a student is sitting in front of you and you're making him understand, is actually very impressive. Thank you so much, and we'll request you for our further associations also, and help us and support us in this venture. Thank you so much, Dr. Nakra.
Yeah, absolutely, ma'am. It'll be my pleasure to be associated with the college in any form, ma'am.
So from the Astron Institute and from Dr. Neeru Bhatia side, my sincere thanks also to you, Dr. Munish. It was a very good presentation. And as she said, we look forward to more collaborations with you in future. Thank you.
Yes, sir. So I just have a question regarding the ICU indicator. My name is Junaid, and I just want to understand the 5th edition, NABH 5th edition indicator for ICU. It is the mortality ratio. Can you please elaborate on that?
Yeah. Great. I'm happy that you brought this up. Can I see your face? I can't see your face. Maybe that's okay. That's perfectly fine, because this was something that is something which is very close to my heart, and this is something that we were doing even before it came up in the NABH. So the standardized mortality ratio, or a standardized mortality rate, as a lot of people call it. Now, what you really have to do is, can I ask you, you practice as what?
Yeah, where are you practicing, please? Can you just state?
I'm a quality manager.
Okay, great. Oh, perfect. This you will understand absolutely perfectly then. So, so a lot of times what happens is, when a person comes to us in the ICU, we score him. We score him by doing a Apache 2 score. You could use any score, but what we do is Apache 2. Now, what does it really mean? It means that, okay, so first thing, we did not talk about a standardized mortality ratio or a standard mortality rate, because it was not an infection control. Okay? It is not an infection control. Now, so Apache 2 we take, and Apache 2 gives you an estimated rate of this thing of what is going to be the mortality, right? So suppose you say you got an Apache 2 of 25, and you expect that your patient has got about a 75% mortality. But when you drop the mortality for the whole month, and you compare the ratio of the expected to the actual which has happened, meaning whatever way. Your actual which has happened is the numerator and your expected is your denominator. And when you are multiplying it by 100 to give you a ratio, if you don't multiply it by 100, it gives you a rate. So when you do that, then you find out if anything is less than 1. Your aim should be, it should be less than 1. Meaning what? Meaning that you expected more patients to be, you have got a lesser number of patients who are dying, and the expected rate was more. That means you have got such an enhanced kind of a care that actually you are saving people who in the normal scene would be dead, right? This is a mechanism by which you can compare different ICU. So somebody says, somebody sitting in Mumbai says that, a certain hospital is doing better than you. I said, no, tell me what is the standardized mortality ratio. I will tell you what is my standardized mortality ratio. That is the way to compare. The way to compare is not that you have. So somebody says, there's a small nursing home. He says, Dr. Saab, we do not have a single death in the last 1 month. You may not have had a single death in the last 1 month, but then you don't even have sicker patients in the last 1 month. Because the sicker patients are coming to us. So what I'm trying to tell you is this is a very good parameter where I spoke personally to the person and I pointed out there's a mistake in the NABH, this thing, as in a typing error. There's a printing error in the NABH manual, which I brought out to the person when he came down for the NABH accreditation. And I told him, I said, with all due regards, this is a mistake. He says, you are the first person who's told me this. And I'm the one who was instrumental in having this parameter introduced. And I told him, this is an error. I know it is error by oversight, but nevertheless, because NABH, this is a Bible for a lot of people. So this error should be corrected. I'm sure that error you would have also realized.
Thank you. Thank you for a wonderful explanation. I'm sure he has answered your question. If there are no more, thank you. If there are no more questions.
One thing, just one thing. So we should come up with an answer with a multiplication or in a ratio part as well.
Any. So to give you an example, if you've got a 75% mortality, but actually you have got a 60%. So you've got percentage on both sides. No? So you use a ratio or you use a rate, anything. It is generally SMR is meant for ratio.
Yeah, MMR is ratio. That's right. Okay, thank you, Dr. Monish. It was a wonderful, presentation as well as the question answers. So all of us stand to benefit. And as Dr. Neeru also mentioned, we look forward to future more collaborations with you on this important area. Thank you. Thank you and good day.